Good afternoon and welcome to today's webinar, Understanding Stroke. My name is Juliana Valencia. I am a social services specialist with Fairfax Area Agency on Aging. Before I introduce today's speaker, I will go over a few housekeeping items. There is a Q&A button where you can submit your questions, and we are going to allocate a few minutes at the end of the presentation to address your questions. Today's session is being recorded and a recording will be sent to all of you by next week. Also, there will be a brief survey as you signed out. Please help us by giving us your feedback. It really helps us create programs that are important to you. Now, it is my pleasure to introduce today's speaker, Dr. Lironn Kraler, who is a board-certified neurologist and a vascular neurologist and a clinical assistant professor at Stanford University School of Medicine. Dr. Kraler is also the Associate Program Director for the Vascular Neurology Fellowship at Stanford. Before joining the faculty at Stanford, Dr. Kraler attended medical school at Keck School of Medicine at the University of Southern California, where she was elected to the Alpha Omega Alpha National Honor Society. She completed her residency training at Stanford Hospital, where she served as chief resident, followed by her vascular neurology fellowship training at Stanford. She then completed a postdoctoral research fellowship at Stanford University's Clinical Excellence Research Center, focused on addressing the high cost of care in the United States hospitals. Her research interests include improving access and quality of population health and developing high-value innovations in care delivery that decrease the cost of care while improving the quality of patients. In addition, she has a strong interest in medical education. Dr. Kraler has received recognition for outstanding medical student teaching from the Department of Neurology. Dr. Kraler, thank you so much for being here with us today, and welcome.
Thank you.
Oh, you're muted. Are you able to unmute yourself?
Classic mistake. Okay. Thank you, Juliana, for that introduction. I am thrilled to be here to discuss a topic that is very near and dear to my heart. I'm going to share my screen. Okay, and we'll get started. Okay, so maybe by way of some additional introduction, yes, I am a stroke neurologist at Stanford Hospital. The reason why I got into neurology in the first place was I was always very fascinated with the brain. You know, from the time that I started learning about it in high school and in undergraduate studies, it was an organ that was extremely fascinating for me to think about. Not just at an intellectual level, but also at a philosophical level. You know, how do we understand the brain, which is in fact the organ that allows us to understand the brain? And so I was always really drawn to the field, but what really drew me to neurology in particular is I started to realize that the diseases of the nervous system, they were so crucial to people's well-being, how they saw themselves, how they integrated in society. And I knew that I wanted to go into medicine, and I knew that I wanted to invest in something that was so worthwhile, so important for patients, so important for society. One of the things that people think about when they think about neurologists is that, you know, that neurologists are very cerebral, but they really, and so they can make a good diagnosis, but they perhaps lack the tools to make a change or to provide a treatment. And you have to look no further than the field of stroke neurology to know that that is simply not the case anymore. You know, the past 10, 20 years have revolutionized the care of stroke. And I imagine that this is close to some of your hearts, you know, coming to this talk today. So I think, you know, stroke touches many people's lives, and we have made some very important advancements in the field, but certainly more to advance. So anyways, this is very germane to my interests, and I'm really glad to share with you a basic understanding of stroke targeted for patients, their loved ones, and caregivers as well. So the outline of what I hope to cover today, and I kept the presentation short, but just to give us, a broad overview on stroke, we'll talk about some statistics about stroke in the United States. What is exactly stroke? What does it mean to have a stroke? And then what are the risk factors for having stroke? What sort of conditions predispose people to suffering from a stroke? We'll talk a little bit about how strokes are treated and some of the modern advances to this field that we've seen. And then talk a little bit about the recovery process for stroke. And then a little bit about tips for loved ones, caregivers, and care partners. And I left a lot of time at the end for questions that come up that are specific to your interests. So stroke in the United States in terms of numbers, to give you a sense of the breadth of this issue. So every year, about 800,000 people in the United States have a stroke. And 1 in every 4 of those people that have a stroke actually had a prior stroke. So this is a recurrent stroke. Now, it is a common cause of death in the United States, the 5th leading cause of death in the United States. Worldwide, it's actually much worse. So in developing nations, stroke causes death much more frequently. But death is not the only thing we worry about with stroke. In fact, one of the more heartbreaking aspects of stroke, or I shouldn't say more, but especially heartbreaking aspects of stroke, is the severe disability that it can cause. These are people who are independent, working, walking, taking care of all their activities of daily living independently, and a stroke happens suddenly and changes the trajectory of their life, some of them forever. So it is a significant cause and one of the leading causes of serious long-term disability in the United States. And there is a common misconception that stroke only occurs in very elderly patients, but stroke actually occurs throughout the lifespan. We see pediatric patients with perinatal stroke, we see young adults with stroke, and then we see middle-aged and older adults with stroke of a variety of different mechanisms. But this is a disease that really impacts the spectrum of age ranges. As I mentioned, there are a significant number of stroke survivors that are dependent on others for their activities of daily living, and that's estimated at about 30 to 40% of stroke survivors. And this may seem, very sad, and it will make you feel despondent and disillusioned perhaps, but what I want to really emphasize today is that we think about 80% of strokes are preventable, meaning they're caused by conditions that, if treated early and aggressively, can reduce the risk of a stroke significantly. So if there's one thing I want you to take away from today is the strategies that we can employ to reduce our collective risk of stroke. So before getting into some details, let's talk about what a stroke is exactly. So a stroke is a broad term that has a number of different definitions. Broadly speaking, a stroke is some pathology of the brain vessels, blood vessels in the brain. And one of the most common types of stroke is something called an ischemic stroke. So in this schematic here on the screen, you can see that this is the brain, and here are blood vessels that are traveling around the brain and then pierce into the brain to provide blood supply. And if you magnify what's going on here, you can see that there is a sudden blockage that developed in a blood vessel going to the brain. So what happens when suddenly there's an interruption to blood flow to the brain? Well, that part of the brain that was receiving blood flow is no longer receiving oxygen and necessary nutrients to keep that brain alive. So within seconds to minutes, a person with a stroke experiences brain dysfunction. A different type of stroke is something called a hemorrhagic stroke. Now, instead of an ischemic stroke where the blood vessel is suddenly blocked, A hemorrhagic stroke has to do with a blood vessel inside the brain that bursts. And this has a number of causes, but the most common is high blood pressure. And we'll get into this a little bit later, but high blood pressure is also one of the more common causes of ischemic strokes as well. The last major subtype of stroke is something called a subarachnoid hemorrhage or a ruptured aneurysm. And this is a slightly different pathology. Here you could see that the blood vessels that are going to the brain develop a weakening in the wall. So there is an outpouching, and that's called an aneurysm. And that can develop from a number of causes, including high blood pressure. And as that aneurysm grows, the wall of the blood vessel gets weaker and weaker and can rupture. Now, this bleeding will occur around the brain and cause significant irritation to the brain and the blood vessels. Conversely, the hemorrhagic stroke is a hemorrhage into the brain tissue, causing a hematoma to form in the brain tissue. Now, for the purpose of today's talk, we'll be focusing primarily on how ischemic strokes are treated, but the prevention strategies apply actually to all stroke subtypes, because we'll see that there's a common theme of how risk factors cause stroke. And the reason to focus on ischemic stroke is, as you can see, by far and away, 83% of strokes approximately are ischemic strokes. 10% of strokes are hemorrhagic, and 3% of strokes are related to aneurysmal rupture. So we'll be focusing primarily on ischemic strokes for today. So what are the...
Dr. Kraler, this is Juliana.
Yes.
Just a quick ask. Are you able to move the black bar that is at the bottom?
Of course.
Minimize it? Thank you, because it is just covering the closed captioning.
Thank you for letting me know, Juliana. How's that?
That's better. Are you able to minimize it? If not, that became bigger. That's perfect. I think that'll work.
Sorry about that. For some reason,
okay.
It's not hiding. And I apologize for covering the closed captioning. Thank you for letting me know, Juliana. So let's talk for a second about what are symptoms of a stroke. Now, it's been a huge leap in public health education that many people actually know the symptoms of a stroke, but let's go through that for a second. So I mentioned that strokes are very sudden occurrences. So when a blood vessel is blocked or a blood vessel ruptures, it causes symptoms within seconds to minutes. These are not symptoms that evolve over days to weeks to months. This is a really sudden disease. And it's sort of like an earthquake, if you think about. Stroke is, the severity of the stroke is really dependent on the magnitude, like the earthquake. So, how big is it? How strong is it? And the other very important component of a stroke is where it occurs. Does it occur in a very densely populated area? Does it occur in a part of the brain that is particularly important for certain functions? And where the stroke occurs directly relates to what symptoms people have. So, for example, maybe I'll take a step back and say, there's a common refrain in pop culture thinking about, are you a left brain person or a right brain person? And that's fun to think about, but in practice, there's not such a distinction. In neurology, there is a left half of the brain and there is a right half of the brain, but both halves provide critical function, but different function. So in the left half of the brain controls strength and sensation on the right side of the body. So the brain is wired in this contralateral fashion. So people who experience a stroke on the left side of their brain might experience right-sided weakness, right-sided numbness, loss of vision on the right side. They may experience slurred speech, and in particular, they may experience language difficulties. Now, what's very interesting about the left half of the brain is that in the majority of the population, language is located on the left side of the brain. So that's the part of the brain that registers what words mean and how to put language together to communicate to other people. So when patients have strokes on the left half of their brain, they experience potentially immediate weakness, paralysis on the right side of the body, and an inability to communicate. So you can see already how difficult it is for stroke patients to get urgent care if they have communication difficulties. Now let's compare that to the right side of the brain. The right side of the brain, of course, controls now left-sided strength and sensation. So patients who experience a stroke on the right side of the brain will potentially experience weakness on the left side, numbness on the left side, loss of peripheral vision on the left side, slurred speech. And instead of language difficulties, right brain strokes have a very interesting quality of something called neglect. So that is the awareness of the world around them, awareness particularly of the left side of the world, their left body, and also an awareness about what's happening to them. So interestingly, people with right brain strokes can have a neglect of their own condition. So the classic description is somebody is paralyzed on the left side suddenly, and they don't seem to grasp the gravity or that there's even really anything going on. So this is a person who is not presenting to medical attention because they may not really grasp that something is happening. Now, the last part of the brain that's very important to discuss in terms of symptoms is the brainstem, which is the lower part of the brain. And symptoms of brainstem stroke could include double vision, a sensation of vertigo that comes on really abruptly, again, slurred speech. You could see that slurred speech is a very non-specific symptom, can be caused by stroke in many parts of the brain. The brainstem can also cause bilateral weakness and imbalance. And again, all of these symptoms as they relate to stroke are sudden in onset, evolving over seconds to minutes. And now that we have stroke therapies, which I'll talk about in a little bit, it's very important to educate the public about stroke symptoms so that we can get people to the hospital and to receive care as soon as possible. And so many of you have probably seen a variety of different acronyms out there used for public health education. One of the more popular ones is something known as Be Fast. And this is a pamphlet that we have here at Stanford, but there are many similar ones that exist out there. And this is just to help remind us about the symptoms of a stroke. So be fast. So is there a sudden loss of balance where somebody is suddenly being pushed to one side, they're unable to maintain themselves upright, they cannot walk in a coordinated way, they almost seem intoxicated and it comes on very suddenly. E is for eyes. So is there a sudden loss of vision in one eye or both eyes? F is for face. So does the face look asymmetric or drooping on one side? A is for arms. So is when they're holding up their arms, is one of them drifting down? Is one of their legs drifting down? S is for speech. When they're talking, does it sound slurred? When they're talking, does it make any sense? Do they understand language? And T is very important, and that stands for time. So whenever that blood vessel gets blocked up, time is brain, and it's very important to minimize the amount of damage as much as possible. So what's important for the public to know is if any of these symptoms come up suddenly, time is of the essence, and it's important to go straight away to the emergency room. So let's take a step back and talk about what causes the stroke. So we talked about subtypes of stroke, but how do we get there? How do we get to an ischemic stroke, hemorrhagic stroke, and aneurysmal subarachnoid hemorrhage? Well, there are certainly some risk factors that are not as modifiable or are state dependent in our lives. So our age, of course, is not something yet we can modify in modern medicine. Similarly, our genetics. So many people have, a family history, a strong family history to predispose them to stroke. Cancer is a sort of state-dependent risk factor for stroke as well. Biological sex is a risk factor for stroke. And then in particular for women, menopause is a state-dependent risk factor for stroke, perimenopause and menopause. And then pregnancy is a situational risk factor for stroke. But there are many very potent modifiable risk factors for stroke. And earlier in the talk, I mentioned that we think about 80% of strokes are preventable. And this is very much related to the information on this slide. So what's listed here are modifiable, meaning changeable risk factors that predispose to stroke. So one category is lifestyle, and it's very much a product of our modern society that many people just have a significant physical inactivity, sedentary lifestyle, sitting in a desk for long periods of time, that can predispose to stroke. Tobacco smoking, fortunately, cigarette smoking has gone down in the United States, but around the world, tobacco smoking is still very prevalent. And then unfortunately, of course, we've seen the replacement of tobacco smoking with vaping, particularly in younger generations, and that also holds a risk factor for stroke. Alcohol use and excess is a risk factor for stroke, and other drug use, cocaine, methamphetamine, marijuana, and then diet. So high fat, highly processed diet can predispose to stroke. The specific medical conditions that relate to stroke, and of course you'll realize that all of these are very much intertwined with one another. Medical conditions, so high blood pressure or hypertension is by far and away the most common and most potent modifiable risk factor for stroke. High cholesterol, type 1 and type 2 diabetes, obesity, heart disease, a specific type of heart arrhythmia called atrial fibrillation, and carotid stenosis, which is plaque buildup in the main blood vessel that goes to the brain. And all of these risk factors play into ischemic stroke, hemorrhagic stroke, and ruptured aneurysm, essentially because they cause, all of them, damage to the blood vessel wall. So this plaque buildup here that I'm circling with the mouse, that's cholesterol buildup in the wall of the blood vessel. And when you have high cholesterol and high blood pressure that's pounding away at the blood vessels, over time, they become injured and build up plaque and have the potential to clot off. Now, plaque buildup is, very much a part of getting older. Everybody has plaque buildup at some point in their lives, but the point is, to minimize that as much as possible. So how do we reduce our risk of stroke? Let's talk about the most potent modifiable risk factors. So hypertension, if treating hypertension can lead to a reduction in stroke about 30 to 40%. So that's huge. And hypertension is something that I talk about in clinic ad nauseum with my patients. I probably should just record myself saying this because it's so important to say for every single patient, but high blood pressure is very common. Probably about 50% of the population has high blood pressure. And we call it the silent killer because people generally do not feel when their blood pressure is elevated. They can feel it when it's elevated to the extremes, but at the degree that it can cause damage, most people don't notice their blood pressure is elevated. So early detection of high blood pressure and early treatment is really important and has the impact potentially of 30 to 40% risk reduction. Smoking, a fascinating risk factor. If you quit smoking, you can actually half your stroke risk related to smoking, about 50% within the year. And then studies show that by 5 years from quitting smoking, essentially your risk normalizes to that of the general population. And high cholesterol with medications, specifically statin medications, lowers the risk of stroke about 20%. So all of these are very meaningful interventions. This is just a graph to demonstrate the impact of high blood pressure as it relates to stroke and heart disease. So on the y-axis here is the incidence or the frequency of stroke and heart disease. So you could see that over time, these lines are all going up because as we age, the risk of stroke and heart disease goes up. But if you look at people based on their blood pressure, you'll notice that a lower blood pressure, this blue line here, is associated with a much less steep curve. So a lower incidence of stroke and heart attack when blood pressure is under 120/80. And this is a typo, I apologize. This should be over 140/90. So on the other end of the spectrum, people who have high blood pressure have a much higher risk of stroke and heart disease. Some additional risk factors that we mentioned that are modifiable are listed here. Alcohol is one of these topics of debate. So you may certainly know that there is some benefit of red wine in terms of heart disease. And studies do show that potentially a glass of wine can be beneficial. If you're not drinking, this is not necessarily a recommendation to start drinking, but just something to keep in mind. Once you go over 1 glass a day, though, there is a significant increase in stroke risk. And so our recommendations are to limit alcohol intake to 1 glass a day or none. And alcohol also, interestingly, causes hypertension. So it's sort of a double whammy. Physical inactivity. So how to address physical inactivity in practical terms. The American Heart Association recommends to engage in cardio at least 5 times a week for at least 30 minutes each time. So that can be a brisk walk, jogging, dancing, swimming, cycling, anything that sort of raises your heart rate a little bit. We're not talking about weightlifting, but sustained cardio activity is very, very beneficial at lowering the risk of stroke and heart attack. And then diet. So I mentioned that unhealthy diet, which is sort of a nebulous term, unhealthy diet causes stroke or increases the risk of stroke. The recommendations are to think about instituting a Mediterranean diet. Now, there are many diets out there, all with different objectives. The Mediterranean diet, though, is specifically a low inflammatory diet to help prevent blood vessel injury and stroke and heart attack. And if you're not familiar with this diet, then there's some information here and some at the end of the talk, which I'll include and will be emailed out. But essentially, the Mediterranean diet is an emphasis on whole fruits, whole vegetables, whole grains, and getting proteins from healthy sources. So that's fish, seafood, legumes, such as chickpeas, nuts, and poultry or lean meat. Getting liquid plant oils in the diet instead of things like butter, and really trying to minimize things that are coming in packages. So beverages, foods with added sugars, ultra processed foods, processed meats, food high in salt, alcoholic beverages. And of course, this is aptly a scale because everything is a balance here. And I don't really consider the Mediterranean a diet in the way that it's restrictive. It's just really what you want to emphasize because these are great sources of nutrition that do not cause, as much injury to the body, so to speak, as some of these other foods. And let me try to move this bar because I'm not sure if it's blocking the content. Here are evidence-based recommendations. Sorry, one moment. It looks like I won't be able to hide that. I apologize. Here's just another table view of evidence-based recommendations to reduce the risk of stroke and heart disease. You'll see that it's generally the same information in that chart, but just to emphasize that, we want to think about our diet as, being a balance between, the expenditure, so what we need, and the intake, and not to exceed more than we actually need to maintain a healthy body weight. And that's, very much balance. Okay, so we know what a stroke is, we know what risk factors are for stroke, but what if a stroke occurs? What if it happens suddenly? Well, we tell people, call 911. And why is it? Why do we want people to present to the emergency room as soon as possible and not call their doctor, not go to urgent care, not schedule an appointment for a week or two later? We want them to go straight to the emergency room. And why is that? Well, as I mentioned, over the past couple of decades, the field of acute stroke care has really revolutionized, and we potentially have treatments for people who come in with their stroke. But this is all very time sensitive. So one of the ways in which we know whether patients can benefit from acute stroke treatment is when they come into the hospital and they have stroke symptoms, we immediately get a series of images of their brain, a CT scan, and what's on the screen right now is something called a CT perfusion, which estimates on the left side the size of potentially irreversible brain damage from a stroke, and on the right side, the larger territory of brain damage that could occur if the blood vessel is not opened. So having this imaging is actually very helpful for guiding what type of treatments we can give patients. This may be review for some of you, but the two main treatments that we have for acute stroke are tissue plasminogen activator, otherwise known as TPA, and there's a newer medication on the market called TNK, which works similarly. That's one type of medication. So that's an injected medication, an infusion that essentially works to dissolve the clot, dissolve the blockage that's causing the ischemic stroke. And there are limitations to this treatment. So because it's a very powerful blood thinner, people who have had major surgeries recently may not be able to safely receive this medication. People who have active bleeding cannot receive this medication. People who have hemorrhagic strokes, which is the other stroke subtype we talked about, cannot receive this treatment because that would make the bleeding much worse. But people with acute ischemic strokes who don't have any sort of contraindications to receive this treatment can receive it if given within 4.5 hours. After 4.5 hours, there's a higher risk to receiving this medication, and it may not be as efficacious. Here at Stanford and around the country and around the world, actually, there are clinical trials trying to extend that window, but for now, this is sort of the standard of care. So people presenting to the emergency room with an acute stroke can potentially receive this medication so long as they come in within 4.5 hours. The other potential treatment for a stroke, an ischemic stroke, is something called mechanical thrombectomy. And this is a procedure where a catheter is threaded all the way from the groin up into the brain blood vessels and traps a clot, traps the occlusion that's causing that stroke, and physically pulls it out. both of these interventions can be used together in hopes of opening up this blood vessel. Now, not all strokes can be treated this way. Only strokes that have blockages in a major blood vessel, in a large enough blood vessel, can be treated this way. But these are often very major strokes. When there is a blockage in one of the main blood vessels, they cause significant injury, sometimes a stroke to the entire half of the brain. And so this particular treatment, the ability to remove a clot from one of these blood vessels, has really revolutionized stroke treatment and prevented significant disability and death from stroke. So both of these stroke treatments are time sensitive, and that's why it's so important that if people experience stroke symptoms, that they go immediately to the emergency room. And the best way to do that is by calling 911, because that gets you to the right type of emergency room. Not all hospitals treat strokes, so the emergency medical services help navigate that. I want to cut ahead to sort of life after stroke to just talk a little bit about what are potential residual disability deficit symptoms that people have following a stroke, and they're many layered. So the obvious ones that people can see on the outside are the physical changes. So weakness or paralysis on one side of the body. As a result of weakness and a result of the stroke, people can develop pain on one side of the body, or spasticity, which is that tensing of the muscles on the side of the stroke. Fatigue is incredibly common and can really limit physical activity for people following a stroke. And seizures as well. People who have had a stroke are at risk for developing epilepsy. The other potential changes that occur after a stroke have to do with language. So we talked about how parts of the brain are dedicated to the production of language and the understanding of language. So if people suffer stroke and don't receive timely treatment, or have a large enough stroke that that the damage could not be reversed, they might have residual language difficulties that can really impact their ability to communicate and navigate the world. And then there are a host of cognitive and mood changes that can be present in stroke survivors that are very much under the surface, more difficult to ascertain, even for patients to acknowledge in themselves and their loved ones, and certainly in society as a whole. But these can include cognitive difficulties like memory loss, trouble with complex planning or multitasking. Depression is incredibly common following a stroke, as is anxiety. There's a specific condition called pseudobulbar affect, which is the inappropriate laughter or crying that can happen after certain strokes. And it's sometimes referred to as emotional incontinence, where people cannot control an emotional outburst. And for patients with this condition, it can be incredibly distressing for them. It can be embarrassing, and it can be difficult for other people to understand. And neglect, of course, is a big sort of cognitive deficit that happens following a stroke, especially on the right side of the brain, as we discussed. And so that can manifest in, people with right-sided strokes, not really recognizing the degree to which they're impaired, not really understanding the gravity of their limitations, or, truly neglecting or not noticing one side of their world. Stroke rehabilitation is a very key component of living with stroke. Many people might ask the question, are there medications or are there stem cell therapies that can help advance stroke rehab? And unfortunately, those are all still in research phases. The best intervention for rehabilitation and recovery is having a multidisciplinary team for relearning and reintroducing tasks to help transition people to gain more independence and more satisfaction and increased quality of life. And all these people are such key components to stroke rehabilitation. Oftentimes I feel like the physicians are the least important. So of course, family and friends and caregivers provide an invaluable scaffolding and support system for patients. Nursing, providing bedside care, physical therapy, occupational therapy, and speech therapy are key to relearning some things that have been lost as a result of the stroke, or if unable to relearn, then learning modifications for how to engage in activities of daily living. And if you're not familiar with these specialties, then I'll explain them real quick. So physical therapy is really the type of therapy that's dedicated to strength building and improving movement in certain muscle groups, improving ambulation or walking independently. And occupational therapy is a complement to that. And I've heard a phrase that I really like, and that is that while physical therapy helps you learn how to walk again, occupational therapy helps you learn how to dance again. So it is the type of therapy that helps you get back into the activities that are important for that individual and important to help improve independence. And then speech therapists have a multitude of different therapy that they do. So that includes language and cognitive therapy, swallow therapy, for example, for people who have difficulty swallowing following their strokes. Psychologists and psychiatrists are very much a part of the team for stroke rehabilitation, as are social workers, nutritionists. And the physicians that play a key role in stroke rehab include neurologists like myself, but physiatrists, or otherwise known as physical medicine and rehabilitation doctors, or PM&R, they play a key role in coordinating care for rehab. And it's very important to have this whole team, in addition to your own primary care doctor, in your corner with post-stroke rehabilitation. Real quick, I just wanted to talk a little bit about tips for loved ones and caregivers. So neurologic disability is very often invisible, and it can be very difficult to navigate that for somebody who has no experience with neurologic disability. But the way we like to frame it is, you know, if somebody broke their leg, for example, you would not get angry with them if they could not walk fast enough. We would make modifications for them. And following a stroke, patients with neurologic disability and invisible disability, we have to really be conscientious of the limitations that they may have, or the necessity to really relearn new tasks. So if you are an informal caregiver or a family member without any formal training in rehabilitation, you know, just some things to keep in mind. If you're sharing with your loved one how to do something, or you're asking them to do something, that it helps to demonstrate that task physically while making eye contact. If it's a very complex task, then breaking it down into smaller steps is very important. And slow, clear communication will be the best way to engage. And this is something that I include here because it's just something important to think about. Patients who suffer from aphasia or language difficulties following their stroke sometimes express a lot of frustration when people finish their sentences for them. And I think that's a natural tendency for people to want to try to help and to fill in the words that, you know, your loved one is not able to reach. And for some patients that may be fine, but some patients really do find it frustrating to have other people finish their sentences. So it's important to be aware, you know, how to best communicate with a stroke survivor. And then of course, recovery and rehabilitation is a marathon. We don't expect recovery to happen over minutes, hours, days, but really months and years. And sometimes disability really is permanent, unfortunately. So finding acceptance with a new normal is really key to finding happiness. And specific tips for loved ones and caregivers, of course, is to take care of yourself. We know that caregiving, both formal and informal caregiving, is critical to so many aspects of stroke care and other types of care. But caregivers, being a caregiver can truly impact your own health and well-being, and this is a societal unmet need. So, one public service announcement is, of course, for all caregivers to exercise, eat well, connect with other caregivers for support, and I will share with you a video that we produced at Stanford to help with stroke education that will just sort of really re-emphasize the things that I mentioned in the stroke, in the talk earlier, sorry. So I'll play that right now.
You already know that staying in shape is one of the best ways to keep your body healthy. But did you know that goes for your brain too? The healthier you are, the less likely you are to have a stroke. Contrary to popular belief, strokes don't just happen to the elderly. They could occur in just about any of us, although some of us are obviously more susceptible than others. So, who is more susceptible? Well, it really all comes down to risk factors. Now, some risk factors are just a part of life. They are part of what makes you you, and you can't do a darn thing about them. We're talking about your age, your gender, good old family history, untreated heart disease or atrial fibrillation. That's irregular heartbeat for those of us without a medical degree. But there are plenty of risk factors that you do have some control over. I'm sure you know most of these already. But humor me. I'll promise to make it quick. Stop smoking, moderate alcohol consumption, control your blood pressure, lower and manage your cholesterol, stay physically active, improve your diet, control your blood sugar levels if you have diabetes. Right. So now we understand who's at risk. But equally important is learning the signs of a stroke so you can take action immediately. Be fast. Yup, it's an acronym. Let me spell it out for you. B equals balance. Is there a sudden loss of balance? E for eyes. Is there a sudden loss of vision in one or both eyes? F equals face. Does the person's face look uneven? A for arm. Does one arm drift down? Ask the person to raise both arms. S for speech. Does their speech sound strange? Ask them to repeat a phrase. And T for time. There you go. You knew that one was coming, didn't you? Every second, brain cells die during a stroke. Time is brain. So, what do you do at the first sign of someone having a stroke? You dial 911. There is no time to waste. So remember, at first signs of stroke, be fast.
There you have it. I didn't even need to give this talk. It was all there. All right, so major take-home points. Stroke is a leading cause of major disability, and the majority of strokes we think are preventable with good blood pressure control, regular exercise, healthy diet, and smoking cessation. Remember the signs of stroke, be fast, and remember that stroke, like a heart attack, is a medical emergency, and this is exactly what the 911 system is for. So if you or someone you know has a stroke, it is very important to immediately call 911 to get timely care. And then, of course, stroke rehabilitation is a team effort, and everyone has a very important role. I've included at the end of the talk some additional stroke resources for patients, for caregivers, or just for interested people. And there are more tips at the end of the slide deck in terms of, understanding the Mediterranean diet, what to eat, and tips for eating both at home and eating out, which I won't go through, but will be there for your reference. So thank you so much for your attention today. I would love to take any questions or comments. I've included below the link to the Stanford Stroke Center with some more information about research and education that we do. And then if you're on Twitter, you can follow us at Stanford Neuro. All right.
Thank you so much, Dr. Kraler. We actually have a few questions. I do want to invite the audience at this point to submit all the questions that you may have. That was very, very informative and very easy to follow and understand. So thank you so much for that. So our first question comes from the audience, and it says, my husband had momentarily low blood pressure several times over a few months before his ischemic stroke. Is this a precursor to strokes? We did talk to several doctors, but no one checked.
Yeah, it's very difficult to remark on specific situations, but sometimes low blood pressure is an indication of heart disease. And so while low blood pressure does not specifically lead to stroke, low blood pressure and what causes it can overlap with stroke risk. So low blood pressure caused by heart disease, low blood pressure caused by other nervous system diseases can overlap with the conditions that cause stroke. I hope that was an answer to the question.
Okay, thank you. Another question that we have from the audience is, what alternatives are available if cannot be treated with clot busters?
That's really the those two interventions, the clot busting medication and the clot removal procedure, are the only two interventions for acute stroke, that is to, undo that blockage that we have currently. So that's why it's so important to get that care as soon as possible.
Very good. And another question that we have is, after a TAI, even though no visible brain damage, can you have similar effects like fatigue and seizures?
Yeah, that's a great question. So a TIA for the audience is essentially a stroke, but a temporary one. So there is a blockage that occurs in a blood vessel, but the body dissolves that clot on its own before it causes any injury to the brain. And so if you do a CT scan or an MRI, you see that there's no injury of the brain. And so we don't expect that after a TIA that you would have the same symptoms of a stroke, because it does not lead to permanent damage of the brain. But again, we have to step back and look at the larger picture. The things that cause the TIA and cause the stroke in the beginning, in the first place to develop, may be the cause of the fatigue, the decline in general health. So whenever somebody has a stroke or a TIA, it's imperative to work with a neurologist and the primary care doctor to really uncover the stroke risk factors that are causing these symptoms and could also cause a recurrent stroke or TIA.
Very interesting. Another question that we have is diet. It's regarding to diet and blood vessels. How do ultra-processed foods damage blood vessels? Do high amounts of caffeine damage blood vessels? Does calcium taken for osteoporosis build up or damage the blood vessels? I have heard of vessels showing up on x-rays showing calcification, and wondered if that was caused by taking calcium tablets or just aging.
Great question. So I'll answer those in order. So in terms of ultra processed foods, so the understanding of ultra processed foods, meaning foods that come in a package that have a lot of added sugar, refined sugars, fats, and addition, food coloring and preservatives to maintain their shelf life. There are a lot of components in that that can be pro-inflammatory. So that's just, broadly speaking, these foods can, contribute to diabetes, contribute to obesity, just because they tend to have a very high glycemic index. They don't have, balanced components oftentimes, and the intake of them can really just exacerbate heart disease, hypertension, cholesterol, diabetes, but also themselves, the components of them are thought to also contribute to blood vessel injury directly. Now, the question about caffeine is a great one. So caffeine, we actually believe, is quite protective for the brain. The exact mechanism we don't know, but we do see correlations between a mild to modest amount of caffeine intake and good cognitive function. Where it can be problematic is caffeine in excess. So people who are drinking, way more than your daily recommended amount. I've seen patients in clinic who've told me that they drink 20 cups of coffee a day, which I don't even know how is possible, but that's where you sort of reach a threshold where that's too much caffeine intake, and you can have elevated blood pressure due to that high caffeine intake. So I would say, in general, the general population that's drinking a cup or two of coffee a day, there should be no added risk of stroke with that. It's coffee in excess and the things that are added to the coffee. So we're just talking about black coffee here, not, the venti frappuccino with, extra whipped cream. So once you start getting into, novelty coffee drinks, I think then you start to worry about the impact. And I think the last question about calcium is a great one. So calcium supplements for osteoporosis or for other conditions, they do not contribute to the calcium buildup. It's a very different process, but having to take calcium supplementation is not a factor that promotes plaque buildup, and so you should continue to take that if that's recommended for you.
I see. Thank you. I guess everything in moderation, right? Especially with the food and coffee.
Truly.
Yeah. So our next question says, both parents suffered strokes. Is this something myself and brothers should be concerned about?
Yeah. So I would say that usually there's not a direct one gene that your parents passed on to you that will destine to the same fate that they had. Usually it's a combination of conditions, and you may know this in your own experience, that there tend to be clusters of families with, the combination of high blood pressure, cholesterol, diabetes. So it's usually those things that run in the family. So what I would suggest for people who have a strong family history of heart disease or stroke, and I say them sort of interchangeably because they're very similar. The things that cause a heart attack are what cause stroke. So if you have a very strong history, my recommendation in general would be to talk to your own primary care physician and let them know so they can screen for those common conditions, high blood pressure, cholesterol, diabetes. And if needed, you could potentially even see a neurologist if there was such a strong family history of young stroke, to think about rare causes of stroke.
So there are things to prevent it, basically, actions that you can take. Absolutely. Great. The next question says, should you take aspirin meanwhile or until 911 shows up? I guess while it's happening, maybe?
Yeah, great question. So the problem is that, for the audience, aspirin is a blood thinning medication, and people who've had stroke or heart attacks, they should be on a baby aspirin to help reduce the risk of having another stroke or heart attack. But the question is, if you're having a sudden stroke, should you take aspirin, since it does have some blood thinning qualities, before you get to the hospital to get, care? And some people do that. The only caveat, the only challenge with that is that you can't know whether you're having an ischemic stroke or a hemorrhagic stroke until you get a CT scan of the head to make sure that there's no bleeding. So by probability, the majority of strokes are ischemic strokes, as we talked about. And so the majority of strokes would be potentially benefited by taking a baby aspirin in that moment. But we don't know for certain that those symptoms are not related to a hemorrhage in the brain, in which case the aspirin, could make the hemorrhage worse. So that's the one caveat. So hopefully you don't have to make medical decisions by yourself, you can get to the hospital as soon as possible.
Yeah, I guess if you're trying to help yourself, and then you know, it's kind of a double whammy. You're trying to help, but you might not. You might create a bigger problem. So yeah, okay, good to be aware of that. The next question says, are there good brain or memory exercises that have been shown to improve aging or that will help with the stroke recovery?
Yeah, so the good news is that it's nothing fancy. So the things that really help maintain cognitive function, help to recover from stroke, and also separately help to reduce the risk of dementia are socialization, frequent socialization. So being out in the community, talking to friends, family, strangers, engaging in conversation, engaging in activities, that is actually very, very protective for cognitive function. There are many programs that will say that they have, sort of mental cognitive exercises that support brain function, but none of them are based in any research. And so I would just caution against spending money to get access to such activities because they may not be necessary, and just your average socialization, being out in the community is very, very protective for the brain function. And the other thing, I talked about exercise as a way to reduce the risk of stroke, but exercise, as low tech as it sounds, exercise is such a protective thing to prevent dementia, to prevent heart attack and stroke. So in the medical community, there's a lot of emphasis on medications, right? Mm-hmm. But there are such low-tech options that are really, really beneficial. So socialization, diet, and exercise cannot be emphasized enough.
Mm-hmm. Thank you. And we are at the end of the hour, but we have a couple of questions. One of them is, what's the difference between, and I'm going to spell this for you, HWART attack and stroke?
That might be a typo, so perhaps heart attack and stroke. So they're very similar. So a heart attack is when one of the blood vessels of the heart is blocked up by a plaque or a clot. And if you think about it, that's exactly what's happening with an ischemic stroke. One of the blood vessels in the brain is blocked with plaque or clot. And so the mechanism is actually very similar. The difference is just where the blockage is occurring. The stroke is occurring in the brain. The heart attack is occurring in the blood vessels of the heart.
I see. So my next question, if you don't mind, if you have a couple more minutes, if you are on a blood thinner to prevent an ischemic stroke, are you at a higher risk of a hemorrhagic stroke?
So aspirin and other blood thinners do carry a risk of bleeding. And that could be bleeding on the skin, so bruising, or bleeding in the GI tract. Aspirin is usually not enough to cause a hemorrhage in the brain, but if you had a hemorrhage in the brain, it has the potential to make it worse. So that's all to say that, we know there's been a lot of press about aspirin. In the past, it used to be, everybody over the age of 40 or 50 should take an aspirin. And now we realize that we should really refine that recommendation to people who have had an ischemic stroke or a heart attack, because in that particular population, the benefit outweighs the risk of bleeding. So while there may be a slightly higher risk of bleeding complications in people who we recommend an aspirin, the benefit is much higher than the risk of bleeding.
I see. And our last question, if a person has had a hemorrhagic stroke, is that area stronger or weaker?
If I understand the question correctly, a hemorrhagic stroke causes brain damage similar to an ischemic stroke, but the mechanism is just different. The blood bursts into the brain and disrupts all those neurons in that brain tissue. So people can have the same disability with an ischemic stroke as they do with a hemorrhagic stroke. And the treatments are just very different. I'm not sure if I answered that, but if you're still there, if you want to clarify the question in the chat, I'm happy to take another stab at it.
Thank you. Do you think we should take a brain supplement? Would that help? Have there been any studies about that?
Yeah, so there are supplements that are marketed. Again, same thing with those sort of cognitive exercise. They're based in little to no research, and they oftentimes are very expensive. So there are no additional brain supplements that are known to improve cognitive function or improve stroke recovery. And again, as maybe dissatisfying as it might sound, the basic tenets of good health are the things best to focus on. So a healthy diet and a multivitamin is good, but nothing more exotic than that should be done because there's really not evidence to back it. And as is the challenge with all supplements, they're really not regulated very closely. So we don't know exactly what's in them. And if there are any associated risks, we don't know that.
Yeah, and that's good to know that there aren't really any science behind it. So we're kind of experimenting with our own body when we do that. So we are at the end of the hour, and this has been an excellent presentation. And thank you so much for answering all of the questions that our audience had. We are very, very grateful for your time and for sharing your knowledge, your expertise. Thank you.
Absolutely. Wow, it's been great. Such a pleasure. I wish I could see all the participants, but I hope you have a great day. Thanks for tuning in. And yeah, it's been a pleasure.
Thank you. And to our audience, thank you so much for being with us. And as you signed out, there will be a brief survey. If you can take a moment to answer those questions and help us provide topics that you are interested in. We also want to invite you to our next caregiver webinar, which will be on Wednesday, June 15 from 12 to 1 p.m. And it will be on caring for a loved one with cancer. So have a good afternoon, everyone. Bye.